Hi, I'm Michael Patterson from Eye Centers of Tennessee. Welcome to my YouTube channel. Thank you for coming today. You're going to learn through these videos surgical techniques and innovative technologies that you and your staff will be able to utilize to further patient care. Remember at the end of the video to subscribe down here at the bottom so that you can find further content in the future. Hello, this is Michael Patterson from Eye Centers of Tennessee, and I'm here to show you today how an explant of an ICL, an intraocular Collamer lens from Staar Surgical, is removed. If you'll look here, we go through our old incisions, which are quite easily accessed with just a cannula. You need no new incisions. We put a little lidocaine preservative-free to get good dilation with epinephrine, as well as then take viscoelastic and make sure we get it underneath the IOL as well as on top to create a good space for the ICL to not damage the natural crystalline lens. If you take the BIA manipulator, you can gently rotate the lens to just get one tab above the iris of the ICL. You'll see here that once you have one tab above, you can grab it with a tire and gently hold it right outside. Then take a secondary tire and take a better bite, and one last pull, gently pull, and the ICL should fold on itself and come out of the eye without any problems at all. At this point, you've got the ICL removed and you can replace the next ICL. And you'll see here, we don't even have to place any more viscoelastic in the eye. In fact, you want less ocucoat in the eye during this part of the procedure. That way the viscoelastic will be much easier to remove at the end of the procedure. As you see here, the ICL is slowly injected on top of the crystalline lens with a slight bath of ocucoat, and then the inserter continues to instill and make sure the ICL rotates to its normal planar position. Once the ICL is into the eye, you'll see here that it nicely unfolds easily and is set up above the iris plane. Sometimes you'll get lucky and the ICL will fall posterior to the iris, but it's unlikely. The BIA manipulator is still used at this point to tuck the edges. Again, you want to take real concern that you are not going to put the ICL in the center and touch it, therefore you don't form an anterior cataract. You can see here, once we've gotten that, we place a little bit more viscoelastic because we want to make sure that the distal haptics are in good shape. And we go in with the BIA manipulator on the other side, and we slightly tug on the ICL just underneath the iris as well as on both sides, and place it directly in the sulcus. Once it is placed appropriately and you've got the right size, in this case it's a toric ICL and we're using the Clisto markerless system from Zeiss, and you can see here it's really nice. You don't have to have any marks on the eye for the ICL case. It makes it much more streamlined process. And then we put a little Mycol in the eye and the pupil will constrict nicely without any complications. You see here the Mycol going in and the pupil will come down nicely right over the ICL, and this just helps. They'll pretty much instantly have quality vision within a few minutes, even after an exchange, which is rare. This is a second case of an ICL in another eye. It looks very similar. You can see we just open it with a little lidocaine with epi with the main wound, and then viscoelastic. In this case, we go underneath the IOL on the side just because we already had a space, and take the BIA manipulator once again to elevate just one tag of the ICL out of the sulcus, and again take tires and gently grab it and place it right outside the wound to where you have a secondary tire that will grasp and hold, and then one last slow pull and you'll see the ICL will slowly fold in on itself and come out of the eye. We have viscoelastic in the eye already, as we said, and we don't want too much. And then you can see here the ICL is kind of wanting to unfold the wrong way, so we rotate our wrist all the way over to make sure that it will rotate out. You can see the actual cartridge is turning again so that it will rotate nice and planar, and we will not have any touch of the crystalline lens. And there's the ICL deposited into the anterior chamber. At this point, once it's placed, you want to go ahead and get your BIA manipulator, and probably, if you can, get one of the distal haptic areas at the plate, and I try to go to the furthest one away first. And this is kind of the preferred approach, and you tuck it directly underneath the iris. And you can see here it really tucks very nicely with the BIA manipulator without any problems, and you don't have to touch the center of the crystalline lens. You can see once we've got that, we go to the more proximal haptics and we place those into the sulcus with the manipulator, and it'll slightly go under. Sometimes you'll lose it and it'll slip and you just re-grasp it. The further out on the tip of the edge, the better. Again, we'll turn the toric marker on and we will rinse out the ocucoat with a little BSS just to make sure we've got it all squared away, and then place some Mycol into the eye to make sure it is aligned properly. You'll see that the IOL doesn't move at all. It's a very stable toric ICL, and really without any problems the pupil comes down. The toric markers have already been confirmed, and we do a little hydration of the wounds. This is Michael Patterson from Eye Centers of Tennessee. I hope you learned something from ICL removal and replacement. Thanks.